All right, well, thank you very much. I was delighted with the title of this talk. I love interesting titles, so I now collect them, and this is among the most interesting. So I'm Eric Pauli. I'm a professor of surgery. I'm a trained surgical endoscopist, and about half of my practice is flexible endoscopy, and so we'll talk a little bit about how and when and why we manage ingested foreign bodies, and we'll talk a little bit about laparoscopy at the very end. I'm very conflicted, and I'm going to show you tools and devices that we use to do these procedures that are made by some of the companies that you see here. I'm not making any recommendations about which tool you should use. There are lots of them out there. So just as a background, removing foreign bodies is commonly performed primarily by GI folks. I think that's safe to say, but in many places, surgeons are the local endoscopists, and so I think that we should be up to date on how to do this. The overwhelming majority of them, 80 to 90%, are going to pass without complication, without any need for intervention. But that 10 to 20% that have complications are really where we can intervene. The big stuff we worry about is obstruction, primarily airway obstruction, because that'll kill you quick. But obviously, things like downstream obstruction, perforation, if it's been there long enough, sometimes fistula formation as a chronic sequelae of the obstruction. And 1% of people will require a surgical intervention to manage this problem. So if you think about all of the ingested foreign bodies that are out there, a surgical intervention, something that we would do operatively, is really the overwhelming minority. There are a variety of ways to classify ingested foreign bodies, and this is the classification from the most recent SAGE's manual on flexible endoscopy. And it divides them into a couple of different ways. True foreign bodies, food stuff, iatrogenic, miscellaneous. I mean, I don't know, a miscellaneous drug package for me is a true foreign body because somebody ingested it on purpose, but I digress. And they come in a variety of shapes and sizes. Obviously, you know, we're familiar with the pediatric coin found in the esophagus, you know, the jacks found in the stomach. This is a stent of mine that is in the pylorus. I did not put it in the pylorus. I put it much more proximal to that, and they can migrate downstream. I primarily just divide these into foreign bodies and then food impactions. Food, for me, is not really a foreign body. Most of it's domestic anyway. The things to think about, dentures. Patients with dentures cannot chew very well. That can lead to a food foreign body, but dentures get swallowed an awful lot. We traditionally talk about carpenters and tailors and people who put things in their mouth just as part of their daily job, right? You put the nail in the mouth, instead of hitting it with a hammer, you accidentally swallow it. By and large, intoxicated individuals, though, are the most common group of people that accidentally swallow things. Psychiatric disease is the largest intentional group, as we'll show you, and then prisoners. Now, food impaction, this is probably the most common thing that I see as a surgeon, and the majority of it occurs in the setting of some sort of pathology. And the textbook says esophageal pathology, but as surgeons, I think we all know, we see anastomotic strictures, we see postoperative issues, we see people with gastroparesis. This is where I'm seeing most of the food pathology. And just as a brief slideshow here, this is a coconut Bezor in a gastric bypass patient who felt that coconut rather than coconut chocolate was a better option and kind of ate the whole bag. And coconut forms weird glycosaminoglycans, and it basically made this cast of her gastric pouch, and that's kind of what it looked like endoscopically. This is crab salad. I don't remember what that one was. This is an entire bag of mandarin oranges at a JJ anastomosis that we retrieved endoscopically, and some noodles. And so this stuff comes in all sort of shapes and sizes. Let's talk about who and why this happens to. This is a paper by Hesch et al. That actually looked at a nationwide database of basically objects that had been reported as being swallowed. So these are true foreign bodies, not food. And over the course of time, in the study period they looked at, the total percent of ingested foreign bodies went up. Some of that is probably just how things are reported, but I think the trends are probably pretty reasonably true. Another obvious trend, young children intentionally or accidentally swallow things, and then people in the middle are a little bit more cognizant to not do that, and then as people become a little more older, maybe with a little bit of dementia and mental decline, they tend to swallow things accidentally a little more often. So kind of a bimodal peak. If you break it down into intentional versus accidental, the overwhelming majority of these are just accidental ingestions. And again, if you look at the accidental, as I mentioned earlier, it's intoxicated individuals and a smattering of other things. And then if you look at the intentional foreign bodies, again, these are people with some sort of a mental disability or people who are in police custody or doing something immensely illegal. So where do things get stuck? Well, I mean, anatomically, things get stuck at areas of narrowing, and so we can just kind of work from proximal to distal in the GI tract and think about the cricopharyngeus. In children in particular, the left main stem and the area of the aortic arch are a very common place for coins to get stuck. The GE junction, obviously, is the next anatomic, and then any spot along the way that there's a web or a stricture, and obviously with reflux disease being very common, we commonly see strictures or webs at the EG junction where things can get stuck. In the stomach, it's really just the pylorus, although I will say that for very long objects, some objects are long enough that they cannot make the bend along the incisura to transition kind of from body to the prepyloric stomach. And then in the duodenum, it's basically just the duodenal sweep, right? If a long, rigid object gets impacted in that duodenum, it simply can't make the bend around the corner. Think about a ship stuck in the Suez Canal. So what do we care about when we meet these folks? I really care about one thing, and is this patient perforated? That's the main thing I'm thinking about right now, because if they are, we're probably going to the operating room, okay? And I say probably because we've done some novel and interesting endoscopic things that are a little beyond the area of this talk, but, you know, I think most of the time we're going to the operating room. So, you know, we want to know how and when and what they ingested, but as I mentioned earlier, these folks may have mental disabilities, psychiatric illnesses, or be blatantly intoxicated, and so getting a good history on exactly what did you do can be a little bit hard. You want to look for physical signs of obstruction. And again, we talked about airway being the most important thing, followed by signs of GI tract obstruction. People who can't tolerate their own oral secretions obviously are a very high risk of an airway issue. And then we're looking for signs of obstruction. I mean, leukocytosis is the main thing we're looking for. And then we're going to look at plain films to start, AP and lateral, although plain films have a very high false negative rate. You know, the quantity of things that one can ingest includes many things that are not radio opaque, and that's really where people get into some trouble, and I'll show you a video of that in a little bit. CAT scans are much more sensitive and much more specific to detect foreign bodies, and I would say that it's the diagnostic test of choice, and many times we just forgo the plain films and just go right to the CT scan. So when do we go get these things endoscopically? There are some guidelines that I think are true, and like if you're going to take one slide home from the talk, it's probably this slide. So people with a complete or a partial GI tract obstruction, we're going to go and alleviate that obstruction. Sharp or pointed objects within reach of an endoscope should be gone after. Disc batteries, generally we say just in the esophagus, but honestly, if there's a disc battery anywhere within reach, I'm going to go get it. Disc batteries in particular, because the positive and negative terminal are in contact at the same time, create a local environment where you're actually discharging energy and it'll burn through the GI tract pretty quickly. And children obviously are at the highest risk for that. Magnets, especially if there's more than one, but a magnet plus metal can be a problem. A magnet plus a belt buckle that you're wearing can be a problem, and they'll lead to fistula. And so if there's a magnet, I typically go after it. Objects larger than 2 to 2.5 centimeters, longer than 5 to 6 centimeters are unlikely to pass, and so we go after those as well. And then less urgently, maybe not what happened on call, but maybe what we referred to somebody else after the night of call, you know, things that are there for 3 or 4 weeks, we would go after. So what are the main principles that we follow? A, protect the airway. I think I've said that enough. Plan ahead. You got to know what tools and options are available to go and get these things. And there are a wide array of things that could be in your hospital and maybe are, but also maybe aren't. And so before you go and try and get something and ask for the tool that you saw me show, make sure that you have the tool that I'm showing you. Because if you ask for it and you don't have it, then you can't use it. The sharp end of the thing should come out last, right? You kind of want to drag the sharp end out. You don't want to aim it. Obviously, if the object has 2 sharp ends, you're in a little bit more of a difficult situation. You can push things gently into the stomach. We do that a lot with impacted food boluses. Again, I say gently because we don't want to cause a perforation. And we're going to do things to protect especially the esophagus. That includes using some tools and some basic principles. Make sure you get them all out, okay? Just because you see one radio-opaque thing and you get it out does not mean that you're not leaving something that is non-radio-opaque behind. We always want to inspect for iatrogenic damage at the end, and don't forget to think about or manage the underlying pathology. Biopsy the esophagus for eosinophilic esophagitis. Do a stricture dilation if they have gastroesophageal reflux. Let's just go over some retrieval devices. There are a wide array of snares, and they come in various shapes and sizes. There are nets that are designed for single grasp or for multi-purpose to go back in and scoop things out repeatedly. There are a wide array of baskets for stones, for graspers that can be used for this with various size, opening and closing jaws. There are some specialty graspers. These are both designed for coins. That one is kind of coin-shaped when you grab it. The other one has little rubber jaws. And so that slippery, wet coin can be grabbed with those rubber jaws and brought out. There are a lot of adjuncts that we use. This is an esophageal overtube, and this is an esophageal length one. There's also a gastric length one. This will protect the entire esophagus. So for example, if there's a razor blade in the stomach and you can pull it into this overtube, you then just pull the entire overtube out and it will protect the esophagus on the way out. This is a device called a foreign body hood that you slip the end of the scope on, kind of like this, and then you fold it backwards. You kind of intussuscept it over the end of the scope, and you go and you do your endoscopy and you get the number 11 blade out there, and then as you pull it back, when you get to the EG junction, that hood will kind of flop forward and protect the sharp ends of things. This is a patient who has achalasia. This is a very common thing that we see in our practice. Patients who have either had therapy for achalasia, are about to get some surgery for achalasia, and you can see the esophagus is impacted here. And we're just going to show you very briefly how to use one of those net-like devices to get it out. This patient actually had already had surgery for their achalasia. They had had a Heller the day before and then received a giant tray of chicken, which evidently that day, according to the cafeteria, counted as a clear liquid diet. It's white meat, I guess. It's at least the clearer of the meats. So this is one of those nets, and you can see we're just kind of putting it down and in, and we're kind of grabbing small boluses, and we will take that in and out. And again, this is one of those overtubes, and the overtube in this particular case is very nice. You know you're going to go in multiple times, and so rather than having to intubate the cricopharyngeus and get in the esophagus time after time after time, you can simply get in and out. I'll be perfectly honest, you can also take some suction tubing and just shove it down there and just pour 500 cc's of saline down there and then just kind of suck it all out. This is a new cap-based device that is designed to also grab large chunks of stuff. I think they originally designed it to do pancreatic debridement, but you can definitely grab big bites of food with it as well. Let's talk about planning ahead. This is a patient who early in the pandemic had ingested that was his denture. And he came in sometime in March of 2020 with some chest discomfort and was told, "There's COVID everywhere, man, get out of here." And they had scanned him and there was nothing on the scan, okay? That's because the entire denture is radio-opaque and they were looking for something that was radio-dense. It's entirely plastic. And it was not visible on the CT scan. And this is now 4 months after it's been there. He had an endoscopy by an outside endoscopist, and they said this can't come out. He then had an endoscopy by our inpatient endoscopy team and was told that he needed an esophageal operation, and they called thoracic, and thoracic called me and said, "Could you just take this out?" So all we did was ask him, "Show us what this looks like." And he showed us the other one, and so we had a picture of it, and we went to the operating room and we said, "Okay, now that we know what this is shaped like, I know what end is embedded, I know where to push and pull this thing, and you're going to see us in about 30 seconds here just rotate it out of the esophageal wall, because we knew which area we could grab, and we knew that that was the flat plate, and it's out, okay? It's now loose, and then we just kind of removed it. You'll see at the very end here, we do some inspection to make sure that the erosion that you see there into the mediastinum was not a full thickness perforation, and it was not. We've put one of those foreign body hoods on here so that as we come through the cricopharyngeus, we don't damage it. It's, again, important to know your tools. This is a small child who had ingested some magnets, and I said we always go after magnets. Now, this child ingested 5 magnets, and you can see on the plain film all 5 magnets are there, and we said we went to get them, and you're going to see exactly why we do this. They are not stacked together. There are 4 on one side, and there's 1 on the other side of the incisura, okay? And it's going to cause a gastric fistula. It's also partly obstructing the gastric outflow. And so just scoping in this particular case, rather than waiting for those objects to pass, meant that we've made a diagnosis that is not radiographic apparent. Now, you can see here that there's an attempt being made to use a metal snare. It turns out that metal is magnetic. And so that did not work out as well as we initially wanted it to. And so what you're going to see us use is a device that is designed not for this purpose at all. It is a plastic, what's called a poly loop. It's essentially a loop ligating device. And it's primarily made to, put on the stalk of a polyp before you do a polypectomy. But it essentially functions like a plastic snare. And it turns out that plastic is not magnetic, and so that actually works very well for that purpose. And so here comes the plastic snare, which again was just a matter of us saying, hey, what do we have that's plastic that's kind of like a loop? And so we put that around, we go to the bottom, and then we just kind of rotate the scope, and the magnets disconnect. The 5th magnet, once it was free, we just intentionally put a metal grasper in it. It just hopped right to the magnet, and we got it out. So just having some tools in your back pocket and understanding what's in your endoscopy cart is sort of helpful. Little scope rotation, and they're off. All right, I'll skip over this slide in the interest of time. Position the patient. You can roll foreign objects around. Use fluoroscopy. Laparoscopic retrieval. There's almost nothing in the literature on laparoscopic retrieval. The SAGES manual has never had a chapter on laparoscopic retrieval of foreign body because it's very uncommon. If you can't get it out endoscopically, if it meets one of those criteria and it needs to come out, then you got to go laparoscopically. The basic principles are to position the ports based on where the object is located. Obviously, the small bowel is able to be moved around. Consider doing combined flex endo plus laparoscopy to help you manipulate objects. And realize that a laparotomy may be necessary if the object is big enough that you couldn't get it out endoscopically. For example, this large bezoar in the stomach, you're going to have to make some kind of a laparotomy to get it out. And at some point, you have to decide, is doing this laparoscopically or open the right option? I'll conclude by saying that foreign bodies mostly pass spontaneously, but you as surgeons should be aware of when to go get them. There's lots of tools available beyond the things that I've shown you. Just know what you have locally. Surgical removal via laparoscopy or laparoendoscopy is possible and remains the last option. So you're still the backstop no matter what. Thank you very much.